Hello everyone, today we'll be talking about syndrome of inappropriate diuresis, also known as SIAD. Some people also refer it to as SIADH, and we'll discuss a little bit about them in this lecture. From previous lecture, you understood that in SIAD, patients have inappropriate ADH response in presence of hyponatremia, and because of the ADH, their urine osmolality is elevated. Now, hyponatremia can result easily in these patients as their urine osmolality is high, so they need smaller amount of free water intake for the same amount of solute before they become hyponatremic. These patients are clinically euvolemic state, so their urine sodium is normal. So there are many patterns of ADH secretions, and let's discuss them because you will understand why SIAD is more appropriate term than SIADH. So in the first type of ADH secretion is seen in patient with lung cancer, where there is a grossly elevated level of ADH which is unresponsive to osmotic deviations. If you look at the diagram in the left, the dotted line represents the normal ADH response. The second type is something called reset osmostat, where the osmotic threshold for ADH release is lowered. So you can see that the curve is now shifted towards left. Third type of ADH secretion pattern is seen in ectopic ADH secretions. In these patients, the ADH is more physiological, but it is neither suppressed by low plasma osmolality nor stimulated by rising plasma osmolality, as seen in green. Another type of inappropriate ADH response is seen in mutations in ADH receptor. So it is on all the time. So you have presence of aquaporin molecules despite absence of ADH. This is seen in the brown line. Next type of ADH response is seen with abnormal baroreceptor signaling. In these patients, any change in blood pressure will cause massive ADH release and thus can cause hyponatremia in these patients. So the type A, B, and C would come under the realms of SIADH, while SIADH will not cover the type D and E response. Thus, SIAD is a more universal term as compared to SIADH. These are the diagnostic criteria for SIAD. Your serum osmolality is less than 275 with urine osmolality of more than 100. You are clinically euvolemic. Your urine sodium is more than 30. And there is absence of adrenal, thyroid, or renal insufficiency, and there has been no recent use of diuretic agents. Whenever you think about SIAD, look at this table, try to figure out which one of these causes is applicable to your patients. So let's look at all these causes one by one. The commonest cause of mild hyponatremia in hospitalized patient is pain, nausea, and stress. In these patients, treat their underlying condition and don't focus too much on their sodium levels. Drugs are possibly the most important cause for moderate to severe hyponatremia, so always review the medication list. Sometimes these medications have been started recently, so ask your patient or family members about them. Psychoactive medications are most commonly implicated in hyponatremia, but there is a long list of medications. SIADH is also seen in lung diseases such as pneumonia, interstitial lung diseases, or any inflammatory lung disease. And the severity of SIADH will depend upon the severity of the inflammation. So if you look at the Port score in pneumonia, sodium is one of the markers for severity of pneumonia. Look for CNS causes because any stroke, hemorrhage, infection, trauma, or psychosis can enhance the ADH release. There is another condition called cerebral salt wasting, which is a rare condition, and we'll talk about that in another lecture. You have to understand that cerebral salt wasting is a different syndrome than SIADH. Cancers can rarely cause SIADH, and the commonest one is small cell lung cancer. Other lung cancers are mostly not associated with hyponatremia. Post-op high ADH state is pretty common, and patient present with decreased urine output. Whenever you have decreased urine output in a post-surgical patient, there are three reasons usually. Either they have developed AKI because of some hypotension during the surgery, they are either pre-renal, that is hypovolemic, or they have high ADH state from post-surgical stress. How do you differentiate between these conditions? The first step is to rule out pre-renal cause by giving them IV fluid. If you give them IV fluids, patients with pre-renal condition will respond very well with increasing urine output. However, patients with AKI and high ADH state will not make any urine. In patients with high ADH state, you can look at their urine osmolality, which will be higher, and you can give them some Lasix, which will result in a good urine response. Patients with AKI will neither respond to fluid or Lasix. So let's see how Lasix results in good urinary response in high ADH states. So if you remember, there is a sodium-potassium 2 chloride channel in the ascending loop of Henle, which result in extrusion of sodium from tubules to the interstitium, and this results in the osmotic gradient in the medulla. In the presence of ADH, there will be aquaporin channels in post-surgical state, which will result in free water absorption, resulting in production of highly concentrated urine and low urine output. If you give these patients Lasix, you're going to block these sodium-potassium 2 chloride channels, and this will result in dilution of the interstitium. If there is no sodium present in the interstitium, the osmotic gradient for the water movement decreases, and even if you have aquaporin channels in presence of ADH, you will not be able to absorb the water, and the water will be lost in the urine. So your urine concentration will fall and your urine output will increase. This is one of the reasons why Lasix is not a cause for hyponatremia. We'll use this principle again when we are treating some patients with SIADH. So in a post-op surgical patient with high ADH state, these patients are very responsive to Lasix and they will dump a lot of urine if you give it to them. In AKI, there will be no response to the diuretics. Patients with pituitary surgeries usually develop SIADH after 5 to 7 days, so watch out for hyponatremia in these patients. So in summary, SIAD is diagnosed by high urine osmolality, a euvolemic state, which is diagnosed by normal urinary sodium, normal TSH, cortisol and renal function, no recent use of diuretics. Most common cause for mild hyponatremia are pneumonia, sepsis, pain, stress, and post-surgical condition. Treat the underlying condition and the sodium will improve. Always review your medication history and look for CNS causes if nothing is apparent. The treatment for SIADH is fluid restriction. Look at my lecture on how to calculate fluid restriction in these patients. We'll discuss other principles of management for hyponatremia and SIADH in the next few lectures. Thank you.